Colleagues here present, distinguished invited guests, members of the media fraternity. It is my honor and privilege on behalf of the Paediatric Association of the Gambia to welcome you all to this, our second international conference covering the theme Optimizing Maternal and Newborn Care in the Gambia, with sub-themes promoting safe motherhood and reducing child mortality. There is no doubt that in the recent past, significant advances have been made in technical and scientific knowledge, but also a recognition of the widening role of pediatricians, especially in developing countries such as ours. This therefore brings to the fore the need for pediatricians to constantly update themselves regarding advances in the practical management of diseases of children, taking into consideration the difficult problems facing the very busy doctor working in a resource-constrained environment. In a resource-constrained environment. As we recognize and celebrate the spectacular advances in pediatrics in recent times, including but not limited to the development of simple but appropriate treatment methods and technology. For example, oral rehydration, kangaroo mother care, KMC, and drugs for the treatment of bacterial, viral, parasitic, blood, and malignant diseases of children. However, there has also been setbacks. For example, persistent nosocomial infections and increasing antimicrobial resistance. The mechanisms of many genetic, nutritional, and metabolic disturbances have considerably been clarified, and means of identification of risk factors and early detection of diseases greatly enhanced. The important relationship of the well-being of the mother to that of the child is increasingly becoming recognized, and this is of particular importance in our settings. This has therefore highlighted the importance of appropriate care for pregnant women, the proper management of labor and delivery, adequate care of the newborn infant, and overall organization rather of perinatal care. Needless to say, pediatrics, like all other disciplines of medicine, is following two distinct routes. One is the pursuit of high-tech and ever-narrowing specialization. The other is the increasing realization of child health in a community setting related to family circumstances, especially the health and welfare of mothers, and influenced by social stresses, economic limitations, cultural attitudes and practices, the environment, and policy decisions and priorities. Both routes are important to pursue in the interest of the overall development of pediatrics. It is increasingly also being recognized that the environment remains one of the major determinants of child and maternal health. The balance of influence changes in favor of the child and mother, where there is peace, stability, education, economic growth, more equitable distribution of resources, and strong political will and commitment to improve the health and well-being of mothers and their children. Conversely, political and national conflicts, international constraints have profoundly damaging effects on child and maternal health by diminishing government budgets available for service provision, decreased parental employment and income, among other things. Worth mentioning is also the grim consequences of natural and man-made disasters, which highlight the vulnerability of mothers and children. Also, increasingly efficient and deeply penetrating communication in a shrinking globe through social media has exposed our cultural and traditional ways of life to stimuli, advantages, disadvantages, and distortions by other cultures. Our well-known extended family units that have buffered mothers and their children from severe physical, mental, and social deprivation are gradually being eroded. As already mentioned, for far too long, medical practice has largely been skewed towards hospital-based curative care. In recent times, however, doctors, especially pediatricians, are gradually finding a balance between clinical and applied pediatrics, between curative and preventive medical care, between diseases in the individual child in the community and in our healthcare delivery centers, between maternal and child health, whilst recognizing that the mother and the child are biologically and psychologically an inseparable dyad throughout the reproductive life of the mother on the one hand, and the prenatal, neonatal, and early preschool life of the child. As we all know, in the past few decades, great efforts have been put into the reduction of infant mortality in developing countries through primary healthcare interventions, namely immunization programs, oral rehydration fluids for acute diarrhea, use of breastfeeding and growth monitoring, etc. There is no doubt that significant success has been recorded in almost all regions of the world, including some of the poorest countries. It has been well noted, however, that these interventions have not been fully adequate in terms of addressing the fundamental causes of malnutrition and infections early enough to produce the needed long-term impact on the health of the fetus and the newborn. The statistics regarding infant morbidity and mortality still remain grim in countries like ours, signaling the poor and damaging conditions that still prevail in our communities. The statistics also clearly reveal about 50% of infant mortality still occurs in the neonatal period, and 50% of neonatal deaths occur during the first week of life. This therefore strongly suggests that our attention should be focused on providing the needed health care for mothers and their babies for improved survival and well-being. However, we all know too well that in most developing countries, a significant number of pregnant mothers do not receive adequate health care, and many deliveries are still carried out by people with inadequate or no training. Many newborn babies still do not receive the medical care they need at the point of delivery in our community. We also do know that in our context, as in other developing countries, the perinatal period constitutes less than half a percent of the average lifespan. Yet, there are more deaths within this period than during the next 3 decades of life. As already said, the health of the mother is inextricably linked to the survival and health of her children. Needless to say, therefore, maternal health during pregnancy and safe delivery should be given the highest priority in a country like the Gambia. To bring these issues even closer to home, it has been observed that whilst infant mortality and child mortality rates have been decreasing readily in the past decades, the reduction of neonatal mortality still remains elusive. In fact, the statistics is showing that it's on the increase. We therefore need to go back to the drawing board to try to determine why this is so. If we look at the trend and decline in the developed world during the 20th century, it paints a very revealing picture as follows. From 1910 to 1930, both maternal and perinatal mortality rates were high, and this led to licensing of midwives. From 1931 to 1940, maternal mortality gradually declined, but perinatal mortality remained high. During this decade, sulfonamides were used to treat infections. Now, in the next three decades, namely 1941 to 1970, saw a rapid decline of maternal mortality to its current low level, associated with the liberal use of cesarean section, blood transfusion, and antibiotics. But perinatal mortality paradoxically increased, as we are experiencing in the Gambia. Now, from 1970 to 1989, this is our time in Europe, maternal mortality remained low, and perinatal mortality declined substantially to its present low levels, thanks to the introduction of neonatal care units and technological advancements. Finally, to truly understand where we are as a nation, where we are supposed to go, and how to get there, we need to first and foremost develop a good quality data collection system. Now, needless to say, perinatal data is the most reliable index of quality antenatal obstetric and neonatal care, as most deaths in this period are a result of complications of pregnancy and childbirth. To collect this type of data reliably, we do not need to reinvent the wheel, as the modalities of such data collection in developing countries have been well worked out by WHO and other similar organizations. Notwithstanding, it is our collective view as a pediatric association that the following are necessary. One, it must be emphasized that linkage of data in different locations, such as hospitals, community health services, and civil registers, should be explored to provide a more reliable information system for routine surveillance. As you know, we do a lot of research in our hospitals, but there's very limited research in our communities, not to talk about the linkage, which is definitely very low. Secondly, the epidemiology of perinatal mortality is required if effective policies of intervention are to be formulated and put into practice, especially outside the hospitals where a significant number, if not the majority of our births still take place. Three, methodologies should be developed that are simple to use but scientifically sound and which can be utilized at community level. Four, maximal use should be made of collected data with due consideration to quality and consistency. We are very good at doing research, writing papers, just to end up putting them in shelves to gather dust. I think that kind of practice should cease. We should implement based on the data that we collect. Improve understanding of risk factors related to perinatal mortality should make possible timely antenatal interventions and timely referral of high-risk pregnancies. Finally, interest in the community must be stimulated and harnessed at all levels of care to ensure collection of data, their analysis, interpretation, and subsequent action. When I came here as a pediatrician, the first indigenous pediatrician in 1982, I was shocked by many things. Uh, One of them was, of course, the very high level of morbidity and mortality among mothers and children. No way comparable to what one was used to in the developed world. And patients were usually much sicker I mean, something like measles was in its classic form with all the complications, pneumonias, skin problems, noma, uh, serious deformities and loss of tissue in the face secondary to malnutrition. And also malnutrition in its worst forms, culminating kwashiorkor and marasmus, or the combination of the two. This was also coupled with the fact that we were grossly under-resourced. Uh, it, we had like 3, 4 children on a cot. But not only that, the floors were full of mothers and their babies and children. So doing around, you had to literally jump over them and so forth. The level of hygiene was also extremely low. And I just wonder how anybody, including staff, survived in such an environment. The neonatal, so-called neonatal unit also left a lot to be desired, especially in terms of location. It was located, as it is now, in the main building. And deliveries of sick babies, as we know, takes place in the labor ward on the other side of the road. So when sick babies were delivered, and there was hardly any pediatrician present at delivery, no matter how high the risk was. So any small baby that was delivered was simply wrapped by nurses, a piece of cloth that were not even warm. They went out and braved the elements, crossed the street, and went over to the neonatal unit, which was also very poorly resourced. There was hardly any incubator worth mentioning. It was just chambers for growth and just to keep babies a little warm. Nothing like CPAP or other uh, management modalities for asphyxiated babies and so on. And infections were, of course, rampant. That's why when we were to start the postgraduate training program, I was very excited to be involved in the rapid development of pediatrics. And in fact, I was even tasked to sketch the new neonatal unit, which I did together with an architect of GAMWorks. And subsequently, I was joined by the first neonatologist in the postgraduate program, Professor Simon Pius. And we had a series of sessions with GAMWorks architects and engineers to design the neonatal unit, which is now under construction. So hopefully, pretty soon, we'll have the first purpose-built neonatal unit in the Gambia. But this is, of course, just a beginning. As you know, we cannot be satisfied with only one neonatal unit in the country. That means referrals for very sick babies have to come all the way from Basse and beyond to Banjul in poorly equipped ambulances and poorly trained staff to manage them on the way, poorly trained and poorly equipped. So by the time babies arrive, some of them are dead, some are dying, and some are doomed. So we need to do better than that. Ideally, we should endeavor to establish neonatal units in all the general hospitals. That is Birkama, Buyam, Farafenye, Bansang, and Basse, to say the least. And also train staff, specialized pediatric nurses, to be able to take care of these highly demanding and very sick patients. So there's a lot of work that remains to be done, and all we need all hands on deck. And it's only with concerted effort and well targeted interventions that we can really get to where we want to go. So without further ado, I thank you all for your attention, and we are extremely delighted that you have left your busy schedules to come here and grace this occasion, which is very important to us. I thank you very much for your attention.
Thank you so much, Professor Adamasala. I think we can do better. Work closely to ensure that we provide the required training to our students and residents. I'm the chairman of the association, Dr. Sarah, who also taught me in medical school. The postgraduate medical representative, uh, Dr. Njoko, and we appreciate all the great work we do for this country. Uh, when now the list is going down, before I have to recognize so many people who trained me, but it's all getting wide, so numbers. So, but we have Prof. Nyan here. Uh, you know, he did not only train us, but he mentored us and just to continue to support. So, thank you. We also have Dr. Idoku here. He supervised my thesis for postgraduate training. So, Helen Brotherton is here. She was when I was a house officer, I worked under her. So she can still take my license because she has to sign it. As a medical officer, I worked on my electives at Okomo. She was that time the medical officer at MRC. She had to drill us very hard. So we need to recognize her. So we have here so many very important. I'm really impressed with the international nature of this program. So we really want to recognize the visiting scientists. I'm so impressed when I hear the people here and I see the potential that the hospital could get from here. So all the visiting scientists present here, we are really honored that you could make this. So thank you very much for coming. All members of the association here present, we have our erudite professors here, mainly from Nigeria. I started with Nigeria because they formed the board, but really their contribution in uplifting the care is immeasurable. So before they came, you remember that time in pediatrics, we were having deaths like what? So I remember one statistics was saying, I don't know, 40 a month. But then when they came, how we are getting, I think, 12. And I was in one meeting, I say, I don't know what amount of money you're paying, but it can never count for this because the reduction is just remarkable. So thank you for your service. So it's not only Nigeria, but they're from the most Nigeria, Gambia, Cuba. So the chief matron is here and her deputy is my boss. Just patches me around the hospital. So welcome. We have the media. Thank you for coming, Sira and the team and all the media present. Ladies and gentlemen, the young doctors, representatives, and everyone present here, please thank you and we recognize you. So my former president of the West African College of Surgeons used to quote, I think it's a common quote that they say, if you want to go fast, go alone. But if you want to go far, go together. And I think that should be, and that's what I see in this association. We want to go together so that, we always strengthen our weakest link and help each other and so that we can all help achieve our objectives, which is to help our children. Our hospital, the Edward Francis Small Teaching Hospital, is responsible for the training of pediatric doctors, and we are happy to be integral in this association. The hospital will work with the association to provide the necessary training, and together we can provide the optimal training. We hope that we can work together in developing protocols. We see that in other associations, developing guidelines and for treatment. The hospital hopes to explore your potential to develop our research culture in the hospital. Currently in our hospital, I think we are managing only 5 grants. With the level of staff we have here, with the capacity of the people that are in the hospital that is too low. And we think that we work together, you support us, so that we can, by next year, maybe we will be managing 10 grants and continue to improve as we go. So our research culture really need to improve, and I think we can harness the potentials that you have to help us in this area. You are all invited to collaborate with the hospital in the areas of research, and the rest are sort of our support. And I can assure you that our pediatric unit will not be left behind, even though it may be the last to be renovated in the process. But we will continue to make sure that the holistic approach will be taken. The Gambia is in a unique situation where you have a young association and a young postgraduate training program. They could grow together like twins. An unparalleled symbiotic relationship will ensue and it can be continuously nurtured. So this is an opportune time that we have. You have a young postgraduate training, very malleable, and you have an association coming up. So we can really work together, intertwine, and make sure that we align our objectives very well. The team is very apt. You know, those who don't know, I'm now an obstetrician. I mean, anybody who knows Dr. Idoko will know that when I shared the link, I'm an obstetrician now. So the team optimizing maternal and the newborn care in the Gambia, I consider it very apt. And the gains made in obstetrics is still not adequate, but it outranks what we are doing at the neonatal end. And it has already been stated that the health of the mother and the child are significantly linked. So the death in the neonatal level need to be impacted by interventions during pregnancy. I think that at our hospital, we need to consider doing a lot of maternal research that will improve the initial outcome at the neonatal level. This, I think, will help to reduce the perinatal mortalities that we are having. And I've seen that there's a lot of research now going on in that area in MRC, and the hospital will be ready to collaborate in those areas. The hospital stand ready to support the association in asking the right questions and piloting the right answers. We challenge the association to provide appropriate solutions that work, not just replicate research is done in other places. We think that we have to make sure that the solutions we prefer to the Gambian people should be appropriate. In conclusion, once again, this is history in the making, and we are honored to be part of such an initiative. The hospital will continue to be by your side through this journey. Thank you.
Started in 2021, and that training has expanded the frontiers of pediatrics here in the Gambia. Last year, the first conference like this took place at a small room in an hotel not too far away from here. But now, obviously, the conference is expanding. So this is the second one that we are having here. And by the token, this will continue to improve and will improve the capacity we have in the Gambia. 2 years ago, there was a very horrible event that took place here in the Gambia where over 85 of our children died of the acute kidney injury due to contamination of the syrup of diethylene glycol. And one of the um, interventions that took place that time was because we had a nephrologist who noticed this quickly, and that effort really reduced the mortality that we had on our hands. So, as the frontier of pediatrics expands, we discover that the capacity that we have to protect the population will continue to improve. Yet, I admonish the Pediatric Association of the Gambia to ensure that they provide a program that expands pediatric care beyond just the West Coast region or Greater Banjul area to other parts of the country. That is an admonition I will give to you. Then we also look at safeguarding of our population. It's recommended, and we are suggesting that that also should be kept in our mind. Then data and record keeping has to be ramped up, as Professor Salah said, because data is what gives lives. And in anything, and when you plan, data is the key. So my speech is very short, as I've said. And as I conclude, I I want to emphasize, because the pediatric community is still, a pediatric fraternity is still very small here in Gambia. I will advocate that the training of students should be robust, because they can be the representative of this association in the provinces. As I conclude, I want to wish all delegates a successful conference filled with learning and also the capacity to improve our pediatric care in the Gambia. Thank you so much.
Thank you, Mr. Provost. We appreciate all that you do.
Gambia has gone a long way in training. They had their first set of medical doctors from UTG in 2006. And from then, it became necessary that people should occupy places held by their teachers. And Gambia is trying to do that. Gambia, small, yes. Poor, probably. But our people say, whatever a man calls his dog is his name. So you don't ask anybody to call your dog a name for you. And that is why I commend the struggle by the people, many of them sitting here too, who has contributed so much to ensure that postgraduate training takes off in the Gambia. We noticed that after graduating the first set of doctors, they needed to put people who will train others. I have heard about all the struggles, even from the time they sent some people to Taiwan, the misadventure, if you may call it, and they came back and then went to Ghana. Then it became expensive, and then it became of interest that all this training should be brought back here. A lot has been done. A lot has been achieved. A lot will still be achieved. It is a matter of time. It's a matter of struggle and resilience. It's a matter of accepting the training and becoming what we are made to become. The postgraduate training started getting a boost when the sponsorship came. But even before then, some people had had their training sponsored outside the country, but it's expensive. And that means only limited people could be produced. But Gambia needed many more people. And just as Gambia attracts a lot of tourists, we believe that Gambia should also be able to care for the tourists and even from people around them. We have noticed that it's rather expensive to access health in our closest community or our closest country. Why don't we reverse it? And Gambia has started off. In 2014, some departments got partial accreditation, the laboratory. Medicine was denied, internal medicine. Why? Because they had only one indigenous consultant, and the Cubans that were around were about to leave. So they couldn't give them the accreditation. But as at now, things are reversing. All hands are on deck. Professor Nyan is here. I won't stop without mentioning his name, because all the stories I've had has involved him one way or the other. And he may have gray hairs, but he's not tired. And he may need to recruit some people with black hairs and push them to accept. I remember what
My teacher in ONG taught us some time ago while I was a medical student. He said, look, we know you people don't know anything, and we are pushing you. We want you to hold your hand on the wall and jump over. But when you urinate on our head, what do you expect us to do? But then, let me say it, that so far, accreditations have been procured or got. ONG, surgery, pediatrics, internal medicine, family medicine, maxillofacial surgery, even is in top gear that laboratory medicine will soon be accredited. This is stride. It should be sustained. It should not be left unattended. So I commend the people and their funders, and I pray that those who are making it possible for this to be funded should not rest on their oars until Gambia is buoyant enough to generate its fund. Keep getting these people involved, and so that at every point in time, we shall be a step higher than the other. I'm looking forward that very soon too, community health may also receive their own accreditation, so that Gambia will become an exporter of consultants and not dependent on others. I told you, I'm only representing somebody, so let me not add any proverb. Thank you for listening.
Thank you, Professor Joku. If you allow him, you continue to talk and talk and talk. We appreciate you, sir. God bless you, sir. As he was talking, the UNICEF country representative.
I'm delighted to, on behalf of the Minister of Health, declare this second scientific conference of the Paediatric Association of the Gambia open. Before I sit down, I just want to say a quote from a famous American president, Teddy Roosevelt. He once said, "The credit belongs to the man who is in the arena, someone who devotes himself to a worthy cause, someone who knows the great enthusiasms and the great devotions. And if he succeeds, he knows the triumph of high achievement. And if he fails, he does so while daring greatly, so that his place shall never be amongst those cold and timid souls who know neither victory nor defeat." Thank you very much.
Shafi is the country representative of UNICEF, the Gambia. Prior to joining UNICEF, the Gambia country office, on December 1st, 2023, she served as UNICEF Chief of Field Office, Bihar, in India from December 2020 to November 2023. Before that, she had also served as UNICEF Chief of Field Office, Homs and Hammer, in Syria from 2016 to 2018, and UNICEF Deputy Representative in Sudan 2018 to 2020, and Azerbaijan 2014 to 2016, widely traveled. Ms. Shafik has a long experience of working in the humanitarian and development sector. She started her UNICEF career as a national office in Bangladesh 20 years ago and has since served the organization in different capacities, including as chief of HIV and AIDS section in Kathmandu, Nepal, chief of adolescent development and participation in Kathmandu too, Nepal, head of adolescent HIV prevention in Lesotho, and chief and child protection officer in Dhaka, Bangladesh. She has also worked in other organizations, including UNFPA, Expressions Limited, a leading social communication agency in Bangladesh, as well as national and international NGOs like Save the Children. Ms. Shafik, major areas of expertise are adolescent development and participation, HIV and AIDS, social and behavior change, and gender. She is a citizen of Bangladesh and she holds a master's degree in development studies from Institute of Social Studies, the Netherlands, as well as in social science from the University of Dhaka, Bangladesh. I want to present to you a widely traveled woman whose interests she will share with us as we welcome her to deliver the keynote lecture titled State of the Gambian Child and Child Survivor Interventions in the Gambia. Madam, you're welcome. Thank you very much.
All protocol observed duly. I have been introduced as a doctor, but I am not. I'm a social science person, and I know that when the medical professionals you suggest what should be done without changing people's behavior, it's not possible to achieve. Whether the mother to come to the health setting, or the nurse delivering the adequate services, all about people's behavior. And that's why I come in. Thank you so much again for introducing me. I have been with UNICEF for last 23 years in different capacities. And it is my personal passion to contribute to the cause of children in any given context, or I would say to the world. So thank you so much for inviting me. It's so important that we all come together for our little ones who we would like to see that they are surviving and thriving. They are also protected and participating. For the reason, today in the Gambia, if I talk about the statistics, about 1/3 of the girls are getting married before the age of 18. Many of them are becoming mothers before the age of 18. And it cannot be more important than today's discussion to come together to say, how do we break the cycle? How do we make sure every child, every mother in the Gambia are safe and handled with care? It's only a 2.4 million population in the Gambia. Can someone guess what is the percentage of below the age of 19 out of this 2.4 million? A wild guess. How much? 40. 54%. More than half of the population are below the age of 18 or 19 rather, because we took the adolescent definition as well. And if we are not protecting from the very beginning, and I'm so apologetic that I was late to join this meeting because I was meeting Minister of Education discussing exactly similar things. How do we make sure a child has a good start of life? And how can we make it multisectoral? So these are beyond my speech that was written by my colleagues. I'm just saying it from my heart because I think it is so important. Another observation I have, I've been here, as Madame introduced me, for less than a year. I think this is the first gathering besides the FGM gatherings where I see so many female participants. A round of applause for all of you. We cannot talk about mothers without knowing what it means to go through a pregnancy, to deliver a child, to breastfeed a child for 6 months minimum. We will not be able to feel the pain that they go through without having women and their voices around the table. So really, really happy that we have more than 50% or about 50% female participants today. The theme of this event is State of the Gambian Child and Child Survival Interventions in the Gambia. That's what I'm going to talk about. And as I spoke, the first 1,000 days of a child's life is extremely important. And we call it, as UNICEF, the first 1,000 golden days. Because I don't have to really preach anything to you. You all are already converted people. You know from neuroscience perspective how the brain develops during that time. Every eye to eye contact with the mother, with the father, with the family members, every play, every word actually shapes up the child's psychology, mental and physical well-being. And that's why 1,000 golden days are very important. Those are the days, and it actually includes the pregnancy period. So those are the days which are so important for the entire humankind, not only merely for that woman who is pregnant and the child who is unborn or born. It is for the entire mankind, and that's why, or humankind. And that's why it is important that we focus on the foundation of our humankind. Those are the days where they are getting ready for their future and then contribute to the world. Now, this conference provides a vital platform to examine both the strides we have made in child health and the challenges that require urgent attention. It cannot be business as usual. We need to find a way to make things as such that there will be no infant mortality, maternal mortality in this era when we are talking about AI driven power. It's just unnecessary for a mother or a child to die today's world. And these are all manageable. We can manage those cases. Together with the government, development partners, civil society organizations, and communities, UNICEF remains committed to strengthening primary healthcare, broadening immunization coverage, and improving child nutrition, as well as, I would add, the ECD, that really plays a critical role in terms of making sure the immunization coverage, the birth registration. So every child would require a name at the onset of their life. So that's why multisectorality is extremely important when we talk about infant mortality, maternal mortality, and pediatric services. Our shared objectives is to ensure that every child in the Gambia not only survives but thrives, aligning our efforts with the National Development Plan and, of course, the Sustainable Development Goals to uphold the right of every child, be the child born in Banjul or in deep rural areas of Sierra North. Every child has the same right to survive and thrive. The Gambia has made notable progress in maternal and child health. From 2013 to 2020, maternal mortality rate declined from 433 to 289 per 100,000 live births. The child mortality rates for children aged 1 to 5 years fell from 20 to 15 per 1,000 live births. Time to celebrate. However, why this is important for us to get together to understand where we can do even better. We are still far from the SDG targets of 70 per 100,000 live births, maternal mortality, and also 12 per 1,000 live births for child mortality. we are on track, but we are quite far from the SDG targets. Each preventable death, as I was mentioning, represents a profound loss for families and the society. And we must intensify our efforts to address these challenges. In this August gathering, I am sure all the scientific papers will be focusing a lot on what can we do differently in this era, which is 2024. While reductions in child mortality have been achieved, recent reports reveal that more than half of under 5 deaths occur in the neonatal and infant periods at the start of the life. Disturbingly, the latest DHS indicates an increase in neonatal mortality from 22 to 29 per 1,000 live births. In infant mortality from 34 to 42 per 1,000 live births. Many of these fatalities are associated with preventable complications during pregnancy and childbirth. I don't know how many of you have traveled all across the Gambia. I have the privilege to travel and see how mothers and children are really suffering because the primary health care is not always functioning to the fullest. That is the space where they go with a lot of hope that they will get the services. How do we focus on the primary health care? Because that's the closest point for those mothers and children who are in those deep rural areas. And through SDG, we all have promised no child and no one should be left behind. Significant challenges remain in newborn health, particularly concerning access to quality care, emergency obstetric and neonatal services, and appropriate follow-up. Approximately 16% of births in the Gambia still take place at outside the health facilities at home. Without skilled birth attendants, placing both mothers and infants at heightened risk, and that is preventable. The current healthcare system lacks a comprehensive mechanism for identifying high-risk pregnancies, managing complications, ensuring institutional delivery. As I mentioned, 1/3 of the girls below the age of 18 are already married and possibly pregnant. What can we do for them? The moment they are married, they are perceived as neither an adult nor an adolescent. They are in the limbo situation. We need to focus a lot more on adolescents and their health, their adolescent sexual reproductive health is extremely important to prevent that early pregnancy. Many of the infants are actually dying because they are born out of a malnourished girl mother, which is preventable. And that's why we need to all come together. It is not only health's business, it is the business of all the sectors and actors. The current healthcare system, as I mentioned, lacks comprehensive mechanism to identify high-risk pregnancies, managing complications, and of course, ensuring the institution delivery. I have met a number of mothers, particularly young mothers, who do not even know what are the 5 symptoms of emergency obstetric, care cases, or 5 danger signs where they need to seek the services immediately and urgently. Many of the wives or women are left behind alone with many other kids in their care because their husbands or partners traveled to another country or another city for livelihood. So they are all by themselves. And when I asked, why didn't you go to the services? She said, I have too many work to complete. I have too many children to take care of. So I don't have time for myself. And these are the voices that I'm bringing on the table today from the rural areas that I have traveled in last 1 year. Furthermore, emergency care remains insufficient in many hospitals, particularly in rural areas, and the follow-up care system requires reinforcement to enable early identification and intervention in complications. I recently visited Kuntao North Hospital. There is no EMOC there. Mothers are coming and delivering in a very dire situation with no medical services really, made available for them. Very, very little, or very limited medical equipment available there to handle a very complicated case. Recent data underscores an alarming trend in maternal and neonatal mortality in the rural CRR and upper river regions, URR. In the CRR, neonatal mortality rose from 14.5% in 2023 to 17.1% in the first half of 2024, while maternal mortality increased from 239.5 to 343 per 100,000 live births over the same period. This is coming from Health MIS 2024. Now, why I have been talking about multisectorality? If you put a microscope on CRR and URR, people who are Gambian here in this room would understand it very well. Those are the two regions where all the indicators are very low in terms of highest child marriage, highest FGM, lowest nutrition or highest nutrition SAM-MAM cases, as well as those are the regions which are very much impacted by climate change. The river regions, the rivers are getting salinated because of the low-lying, the geographical topography, as well as it is salinating the arable lands. Therefore, there is less food for those mothers and children to access. There are more poverty because predominantly Gambia is an agro-based country. So we need to really think beyond just the service. What are the indicators? What are the elements that are impacting the lives of mothers and children and the families? UNICEF is dedicated in supporting the Ministry of Health, particularly the Directorate of Reproductive, Maternal, Newborn, Child and Adolescent Health, known as RMNCH, to enhance maternal and newborn services within healthcare facilities. Sorry, I forgot one very striking statistics to mention. The URR has also seen four-fold rise in neonatal mortality from 1.1% in 2023 to 4.5% in early 2024. This trajectory is really concerning, and reversing the paramount or the great success that the nation made. There must be something going fundamentally wrong that we need to consider in this event today. So as I was mentioning, our team has conducted assessments of key referral hospitals in collaboration with RMNCH. Also, we are focusing on strengthening infrastructure, improving service quality, enhancing community outreach, which is so important. Additionally, we are supporting the establishment of a new digital monitoring system for tracking the post-discharge care of newborns from the sick newborn care unit. This system will enable improved follow-up, early intervention, and sustained care for vulnerable infants. As we convene today to reflect on achievements and gaps, I urge all stakeholders, government, civil society, healthcare professionals, community leaders, and international partners to continue our collaborative efforts to create an environment in which every child can really grow up healthy, secure, and empowered. The future of the Gambia resets on the health and survival of its children. 1.3 million or 4 million about children. May this conference foster innovative thinking as well as strategic alliances as we chart a path toward healthier and more equitable future for all Gambian children and mothers. UNICEF reaffirms its unwavering commitment to supporting the Gambia's aspirations and will continue working closely with the government and other partners to ensure no child is left behind. On behalf of UNICEF Gambia, I extend my deepest gratitude to the Paediatric Association of the Gambia for organizing this significant conference. I had to remove a few other important meetings to make sure that I come here because it is extremely important for us. So let us seize this moment to share knowledge, cultivate solutions, and reaffirm our commitment to safeguard the well being of every child in the Gambia. Together, we can realize a vision of the Gambia where every child not only survives but thrives and achieves their full potential. I really thank each and every one of you for bringing your knowledge, expertise, experience, and gathering today to discuss how can we make sure that every child survives and thrives in the Gambia, because it is doable and I believe it is achievable with the support of all of you. And I thank you all again.